It's my pleasure to introduce my very close friend, Dr. Paul Ho, graduated from the University of Hong Kong in 1986. He received his surgical training in the Queen Elizabeth Hospital, Hong Kong after graduation and was a fellow of Royal College of Surgeons, Edinburgh. And he was admitted into the Academy of Medicine in 1994 as a specialist in general surgery and was invited to move to Department of Emergency Medicine in 1994. And he was the first to pioneer to develop the trauma care in hospitals across Hong Kong. And he was also the consultant of AADQEH Hong Kong since 1996 and the chief of department during the period of 1999 to 2013 and 2019 till 2021. He was the founding fellow of the Hong Kong College of Emergency Medicine in 1997, and he also helped in the development of trauma care in QEH and in the territory. He assisted to develop trauma systems in Hong Kong through designations of 5 trauma centers in 2003. Pre-hospital diversion network was established and territory trauma data was collected and reviewed. He was the founding chairman of the Central Committee on Trauma Systems Authority, Hong Kong, from 2005 to 2008. And he also then chaired the Central Coordinating Committee of A&D Service at Hong Kong from 2009 to 11. So he was deputized as hospital chief executive of QH from 2013 to 19, and he also was the president of the Hong Kong College of Emergency Medicine from 2011 to 2007. He was the first licensing officer, one of the executive board member of International Federation of Emergency Medicine, and between 2018 to 20, and is the current vice president of International Federation of Emergency Medicine since 2022. His main interests are trauma care, geriatric emergency, end-of-life care, and administrative medicine. With these few words, there are much more publications, dissertations, research, and a lot to come for him. It's my pleasure to invite him to speak on the topic which is very close to our heart for all the residents across the world. Thank you, Dr. Paul, for accepting our invitation and to be the faculty for this particular webinar. Thank you very much.
Thank you, Dr. Srinath, for the kind introductions. Tonight, I would like to spend with you for the next hour on this topic, which is actually very dear to my mind because as in the introduction, I started my training as a surgeon and then moved to the emergency medicine and pioneering the change in trauma care in Hong Kong. And in the late 90s, although we have done quite a lot on improving the trauma care in Hong Kong, but this is condition, the exsanguinating fracture pelvis still have a very high mortality at that time. So I've spent some 20 years time together with my colleagues in orthopedic surgery, in general surgery, and also interventional radiologists to try to help this kind of patient and try to decrease the mortality. So tonight I'm very honored to be invited to share with you some of our journey for the past 20 years. And there are probably some thing that we can share and learn from each other how to make these dreadful conditions less dreadful by saving more people. So this is my hospital 60 years ago. This year, our hospital celebrate our 60th anniversary. So at the time, this is lights and clean, and I was told it was the largest public hospital at the time in Asia. At that time, we have about 2,000 beds. So this is our current situations. And now we are planning to move the hospital to a new site, which is the old airport. And I'm part of the team who is planning that new hospital. So in a few years' time, we will move away from this site and hopefully have a brand new hospital. If you visit Hong Kong, you may come to visit us. So today, my presentation will be divided into these 6 subsections. So there will be some typical presentations of these conditions, how to recognize them, where is the bleeding coming from, how to resuscitate these patients, and we'll talk something about Ebola, which we have started about 3 years ago. on this condition, hopefully try to further decrease the mortality. And whether we should send the patient to the CT scan, angio suite, or the OR is something very dynamic and sometimes difficult decisions. And we need a team agreement because the surgeons, orthopedic surgeon, might have a different thought, might have a different thinking, and we have to have a line. And priority is the I think it's the single most important word in managing trauma, because we don't have a second time, we don't have a second chance, we don't have time to try this and that. So we must choose the right priority and tackle it in the right time, right place, by the right personnel. Now, this is in Chinese, but I translate this for you. It happens quite a long time ago. It's in 2008, in August, in the middle of the night, just past the midnight. So there is a highway, what we call the Princess Margaret Hospital, next to my hospital, Queen Elizabeth. There was a taxi who is just across the harbor, in the cross harbor tunnel, and probably driving in a speed more than 70, 80 kilometers per hour, hit on the rear end or the back end of a road repairing truck. Because those trucks usually repair the highway, the road in the middle of the lights. So they park there, of course, with those warning lights. But the taxi is so fast that when he recognized that there's a truck parked there, he cannot stop. He could not stop the car and run right into the rear end of the truck, and resulting in 1 death and 2 severely injured. So this is the picture. So this is the picture in the middle is that road worker who is helping to repair the highway was standing at the rear end of this truck. When the taxi run in the rear end, he was pinned between the taxi and the truck. So you can imagine that with his height, his pelvis or low abdomen is just between the impact between the 2 cars. So this is his X-ray when he arrived at the hospital. You can see his upper part of the body is relatively spare because the force actually go to the lower part and actually go to the pelvis. You can see this is a very severe fracture pelvis with probably an open book fracture with spraying out of the pelvis, with a fracture of the right ilium bone, and also a lumbar fracture in the pubic rami. So this is another case, just a year follow in 2009, again near midnight, in Malakpet Road, which is a very busy road near my hospital. A minibus was being hit by a double-deck bus, and that minibus ran into the pedestrian pavement and hit a number of pedestrians, resulting in 2 deaths and 7 injured. So this is the picture from the newspaper on the next day. So there's a number of patients lying on the road, on the pavement, requiring rescuer to help them. And this is the text minibus, which was hit by a double-deck bus at the rear end and pushed it into the pedestrian pavement, and hit on a number of pedestrians. So this is the X-ray of that young lady lying on the ground. And this is another type of fracture, which is resulting in a fracture and also of the left pubic rami, and also the separation and fracture of the right SI joint, sacroiliac joint. So this is probably a lateral compression type of fracture. So this is the fracture dislocation of the right SI joint together with a fracture of the pubic rami. So another mechanism of injury is not on the road, but is drawn from a great height. So this is a psychiatric patient suffering from schizophrenia. He's drawn from the flyover, which is quite high, and then resulted in very severe shock. Because our hospital is a trauma center, so this patient was diverted to our hospital. And then after a lumbar X-ray, apart from the extremity fractures, you can see this X-ray. That's the patient actually, this is a kind of vertical shear with the right. He probably land on the ground with his right lower limb. So the force transmits from the leg to the femur and also to the pelvis, causing a fracture of the pubic rami and also fracture and probably some changes and dislocation of the SI joint on the right side. So this is kind of vertical shear with one leg landing on the ground, also resulting, this is a bone injury, but actually what we worry about is not the bone, but it's also the blood losses associated with these fractures. So the typical presentation is a relatively young patients who have suffered from a great force, either from a very severe motor vehicle crash. We also have some patients with industrial accident being compressed and hit or pinned down by a very heavy like cement or marbles. And also these fell from height. And usually result in a cast-free shock. And on the rifle, the blood pressure was very low, apart from tachycardia. And usually there's a multi-system injury. Apart from the pelvis, there may be abdominal injury, there may be other extremity injury. In some cases, there will also be a head injury and also thoracic injury. But for those cases I just mentioned, is the force pinned the body between two great forces resulted in localized injury to the lower part of the body. So typically, when the patient arrives, especially for those patients who is potentially salvageable, are usually conscious without any significant head injury, but very competitive because of the shock and pain. And the pelvis of office unstable, even clinically without an X-ray. But of course, we are not advocating people nowadays to rock the pelvis, or if you have to do it, you just have to do it just once. But nowadays, we usually rather than take X-ray rather than doing this rocking to the pelvis, which can disassemble the clots and causing further bleeding. So it's not advocated nowadays. Now, the mortality from the literature for those very unstable hemodynamic unstable fracture pelvis, the mortality is up to 40 to 60%. Now, this number can be quite variable because we sometimes in the literature is the talking apple to orange. So we are not probably speaking to the same language. Some paper may take about severe fracture pelvis because of the bone injury, but we are talking about hemodynamic unstable patients with a very high mortality. And you look through the treatment algorithm, there are very complex, sometimes even very impractical, because in the middle of the light, as I show you in the two first cases, is in the middle of the light. You probably, unless you are very high volume trauma center, you probably don't have all the specialists like the interventional radiology, like the very expert orthopedic surgeon and general surgeon are in-house. So some of those guidelines and algorithm are not very practical for you to use 24-hour, 24/7, 365 days a year. So usually there are sort of multiple injuries, soft tissue, bladder injury, intra-abdominal injury, and other major. Now, this is lethal track for those who's managing trauma patient know. And because of the blood loss, we can result in hypothermia, which is less severe in Hong Kong, probably in your locations, but in the area that have a very cold weather, it will set in quite rapidly. And acidosis is probably because of the blood loss and metabolic acidosis. And if a lot of blood loss, coagulopathy will slip in. So this is the lethal track for managing trauma patients. So stop breathing can correct or can limit coagulopathy, reduce acidosis, and also reduce lots of vesicular transfusion resulting in hypothermia. So stop the breathing is the main goal. So this is the tunnel to grave or tunnel to heaven. So most of our patients suffer from exsanguinating fracture pelvis. We cannot send the patient to a CT scan until we stabilize them. So this is the priority number one, that we cannot send patient to CT. So this is the priority, not to be put on the CT scan. We know we may miss some injury, but the target is to save life first. So how to recognize and to evaluate these kind of patients? I've probably as incident with great forces. So sometimes it is not always that easy, because if it is has shown it's easy to know there is a breathing, you can control it with whatever means. But our practical assumption is that the patients must suffer from very high energy trauma. Okay, so either in Hong Kong is most likely motor vehicle crash or fell from great height. And the second thing is that we have to rule out those non-hemorrhagic source of shock. The patient will follow the ABC of the primary survey in the ATRS. So we exclude those non-hemorrhagic source of shock like tension pneumothorax or cardiac tamponade. And then if we can exclude that, then we have to find the other source of breathing apart from fracture pelvis. Sometimes it's very obvious, like external breathing, some very swollen limbs, which indicate long bone fractures. And X-ray or chest X-ray or even ultrasound nowadays can help you to diagnose and make the diagnosis of massive hemothorax, which can be another source of breathing. So, and intra-abdominal breathing can be ruled out most of the time, or at least if it is a lot significant intra-abdominal breathing, we can do a EFAS, which can give you an answer. Sometimes very small amounts of breathing, intra-abdominal breathing show up in the EFAS cannot account for the hemodynamic status, then we still have to think about fracture pelvis or retroperitoneal hemorrhage per se. So this is a different kind of classification. I don't bother you with this mechanisms like lateral compression, AP compression, and different categories, type and sort of injury. So so we all understand this is, in a real patient, it may be a combination of those mechanisms. Now, in managing of trauma patients, we might have a team of doctors and nurses, but I think nowadays I don't go into deep into this vertical or horizontal resuscitations, which you might already know. So in the ATRS, we are taught to resuscitate the patient vertically. That means with time. So you do airway breathing circulations, but in actual fact, we have a team of doctors and nurses. We can do it horizontally. That means at the same time, we can do multiple maneuvers and multiple assessment and management. Just the purpose is to shorten the time in the ED so that the patient can be sent to the definitive area, no matter if it's in the operation theater or the angio suites. So where is the breathing? The breathing from fracture pelvis come from three sources: the bone, the artery, and the vein. So people will tell you, and you read the books, they will tell you that 80% of those patients suffer from fracture pelvis will have a breathing from the bone and the retroperitoneal venous plexus, which seems not that dreadful and easily controllable. And only 50% are from the arterial breathing. But if you remember, our topic today is called exsanguinating fracture pelvis. In that particular subset of patients, you will anticipate many of them have very significant arterial breathing. So this 85% to 50% is in a general view of a comprehensive view to all the different types of fracture pelvis. But for the hemodynamic unstable patients, quite a number of them are suffering from arterial breathing. So since there will be breathing from the vein, from the bone, and from the artery, they have a different maneuver and solutions. So since you cannot send the patient to the CT, you don't have a very accurate assessment, probably just a plain X-ray of the pelvis. What will be your bets? How do you manage patients, and which priority are you going to choose? Are you going to fix the bone with this kind of external visitor, or you do the retroperitoneal breathing by the general surgeons or other interventional radiologists to do embolization first? Who should be done first? Okay. So breathing from bone, either anterior by this anterior external frame or Hoffman, or by the C-cam, fixing the bone from the posterior element, or even temporarily by this kind of pelvic sling or pelvic binder. So this is try to control breathing from the bone because of the breathing from the, try to close the book, as you can see in this as cross-sectional CT. Now for the vein, is from retroperitoneal packing. So this is a kind of open book fracture. So the surgeon will make a very small wound just below the umbilicus, go subcutaneously and go through the fascia and side of pelvis, and not entering the abdominal cavity to pack the posterior part with gauze roll. This is a way to control the venous breathing because they are low pressure system. For artery, open method is definitely out because it will be very massive and you cannot approach to the very deep pelvis. So nowadays we use the interventional radiology to stop this breathing by endovascular method. So which first? Okay. So next, the patient have a very severe hemipelvectomy, which is obviously easy for you to make the decision. But for most cases, not like that. So when do you start first, the bone, the vein, or the artery? So in the fraction of very kind of exsanguinating fracture pelvis, we assume there will be significant retroperitoneal hemorrhage, no matter the blood is from the bone, from the vein, or from the artery. So our resuscitative measures is follow the ATRS. So given the patient is fully conscious, he don't have any airway problem, he can scream, he can scold people, definitely patent airway. He saturation is 100%, even on a simple mask. We still want to control the airway because the patient was in shock. Once he go into further shock, all the other alarms will be uncontrollable. And I'll talk later because we will involve some painful maneuver, which probably we can control the airway and put the patient on mechanical ventilation and sedate the patient and give painkiller before we do those resuscitation measures. So every now and then we will control the airway and breathing because we take quite a number of years to persuade our anesthesiologists because they are the one that we will summon them to our resuscitation room to help with airway and mechanical ventilation. At those days, they will query that the patient still have a patent airway, didn't have desaturation. Why should we intubate the patients? So we explain to them, and then in a number of occasions after the kind of a M&M meeting, we eventually now it's a one team, though they don't ask. We ask them to do the airway control, they will just do it for us. So large bore IV, peripheral IV is good enough. Try to avoid the femoral or those below the pelvis, because sometimes the patient might have a bilateral upper limb fractures. It causes difficulties for IV access, but don't try to do the femoral IV access because all the blood product or the fluid will go to the pelvis from the broken veins. We hopefully, if at the early stage when it just arrived the ED, still have a palpable pulse, we try to put in arterial line in the upper part of the body, like the arm, the wrist, so that we can have a better monitor the blood pressure, because non-invasive blood pressure is usually not very accurate and underestimate the situations. We need an arterial invasive blood pressure monitoring to guide our treatment. So we'll give blood right away. So we, in our resuscitation room, we have 6 pints of O positive blood always ready. So we didn't need to match the blood, and we use this massive blood transfusion protocol, which I think has been quite popularly used in various centers over the world. So we don't give just crystalloid, but we will start giving blood right at the beginning. So the 6 pints of blood can buy us some time, and then at the same time, we will activate the massive blood transfusion protocol in our hospital, and we'll get another 4 units in a batch in terms of minutes. So if possible, when the patient is still not that bad and still have a palpable, for example, a femoral pulse, or even we use ultrasound, we put in the angiocat or arterial line in the femoral artery, because it will facilitate subsequent angiographic embolization. Because after 30 minutes or 45 minutes of resuscitations, you may not be able to find those pulse, femoral pulse, or even through ultrasound, the femoral artery may be so collapsed, it's very difficult for you to cannulate. So try to do it early at the stage of resuscitations. So pelvic binder is the most easy way to temporarily control not only the bone breathing, but also the pelvic volume to try to decrease the breathing. So we have to put it early. Nowadays in Hong Kong, the ambulance men will already put in the pelvic binder before they arrive to the hospital. So there are various types of homemade pelvic binder, different kind of London Spring, the kind of Geneva bowels I think the mechanism is still the same, but the most important thing is not the equipment, but also but it's the positions, how you put in those pelvic binder. And so these are different kind of binder, which I think is no longer used. Even if you have nothing, you can use a bed sheet to try to close the pelvis temporarily, try to stop the breathing. So this is a more sophisticated commercial like Sam Spring with a patent locking system producing about 34 Newton of forces. But this is what we are using in Hong Kong called the teapot, which can produce a very tight and adjustable tension closing the pelvis. So now the practical skill is that it's no matter what kind of a pelvic binder you're applying, you have to apply the center of those binder over the trochanter of the both femur. So many a time we see the ambulance man putting this just like a lumbar corset. So put it high up into the lower part of the spine. This is completely useless, because if we want to close the pelvis, we have to center the binder over the trochanter of both femur. So this is the correct way, whether it's a sand spring, a teapot, or any other gadgets that you can use to close the pelvis. So remember the position of the binder is the most important. So this is a typical iliac crest. This is the trochanter, and this is the center the binder to the trochanter so that we can close the pelvis. So just like this. So it's much lower than you think, okay? Because many times we see the binder over here. This is completely useless. So since about 3 years ago, we tried to further hopefully improve our result, because some patients still die, as you can see. We're trying to stop or limit the bleeding before we can send the patient to the operation theater. Sometimes we have a problem with having the operation theater always ready. So we use the REBOR, and this is REBOR is a multidisciplinary team. So, and the emergency physicians, so we have these surgeons, with the anesthesiologists, orthopedic surgeons, and the whole team of nurses, and our hospital chief executive actually also help in coordinating all the trauma team members to go about with this maneuver of REBOR. So we have, luckily, we have this endovascular operation theater where we can operate on patient during the angio embolization without moving the patient from the operation theater to the X-ray angio suite. So this is it's lucky that we have this facility. So what we call them 3-in-1 protocol. So because when we send the patient to the operation theater, or even in the A&E, we can put in this pelvic binder, pelvic external fixator to close the pelvis, which the operation can just take about 10 to 15 minutes. They can do the job. And then the general surgeon will go in, pack the pelvis, which is not a major procedure because they didn't need to go into the abdomen. And then the radiologist will be all the way back from home if this is a long office hour. So then they can do the endovascular embolization. So this is our sequence. Fix the bone, pack the pelvis, stop the venous bleeding as much as we can, and then embolize the arterial bleeding. So this is our result. We started in about 2008, and then we can see the mortality actually come initially is around 40%, and then we steadily drop it to about 20. There's something we have to do a monthly trauma and mortality and morbidity meeting. In the year 2021, there is a number of fracture pelvis with multi-organ injury, so that is the reason why there's such a high mortality at that particular year. Otherwise, we can stable our result to around 20%. So this year we haven't ended yet. So so far in the month of September, we have a mortality of about 25%. So we don't have a lot of this kind of major fracture pelvis with exsanguination every year. The number is around 20 to 30 a year, but that is the case the number that we want to prevent from dying from trauma. So before I will not spend a lot of time, but this is what we do in the emergency department. It was done in the emergency department. So we puncture the femoral artery, a common femoral artery, and put in the catheter, and then distend the balloon and occlude the lower part of the abdomen, what we call the zone-free aorta, lower part of the aorta, to stop the arterial bleeding to both sides of the leg. So I have to try to limit and decrease the arterial bleeding. So this is called zone-free, from the celiac artery to the bifurcations, and then above that, from the renal artery to the celiac artery, and then zone 2, we'll do a lot of things on zone 2, but some people will do the zone 1. That means from the celiac artery to the aortic arch, where they will try to replace it with the open thoracotomy, resuscitative thoracotomy in the ED, but we won't do that for our patient with fractured pelvis. So the role is because we cannot transfer patients because it's too unstable, and this is kind of just an adjunct to resuscitation. Try to increase the cardiac output, decrease the breathing, increase the blood pressure, so that we preserve circulation to the brain and to the heart. And it is a kind of alternative to resuscitative thoracotomy, which is a very significant and invasive and procedures, not only to the patient but also to the healthcare providers. So we practice zone-free rebore, and we will allow not more than 2 hours of occlusion. Although some literature said this should be less than 1 hour or as short as possible, we try to limit it to less than 2 hours for our zone-free rebore until we can definitively control the hemorrhage. So our indication is that it must be suffered from a patient with exsanguinating fractured pelvis with all those evident mechanisms of injury, X-ray. We don't need a CT scan to make the diagnosis. The systolic blood pressure is less than 70, so it is really bad patients in terms of hemodynamically, and they are not responsive to fluid or blood, and we can exclude any aortic injury by simple chest X-ray. Okay, and then of course the contraindication is those patients with aortic injury or with aortic pathology. So this is a very complicated flow chart, but now we don't practice zone rebore, so we just practice here. Patient with fractured pelvis, not responsive to resuscitation with a systolic blood pressure less than 70, so we will do a zone-free rebore. Hopefully we can control the breathing for a while and have a better hemodynamic status, and then we send the patient to the operation theater right away. So we modify our T-pod because this T-pod will obscure the inguinal area, our femoral, common femoral artery. So we'll replace the T-pod with this homemade by the occupational therapist. So we'll keep the posterior part of the T-pod and use this valve to adhere to the T-pod, and then tighten it so that we can still have this pelvic binding forces while exposing the femoral area for us to put in our catheter. So we use the ultrasound to make the location of the common femoral artery, and then we use this Toka rescue balloon, which is a Japanese type of balloon because they have a smaller flange, a 7th flange catheter, which is because the smaller catheter, the lesser the complications in terms of distal embolizations or thrombosis of the limbs. So we use the Toka balloon versus those from the American, from the European, where they will use a bigger size, like 8 flange or 8.5 flange. So there's a number of overseas courses that you can go to acquire this technique. But we organize some local training to our staff because obviously it is not viable for us to send a large team of staff overseas to learn this technique. So we organize a local training. So in the end of 2020, we have done a drill within our department. So we practice it with all the observers from different disciplines. And Very luckily or unluckily, just about 2 weeks later, this is November 25th. So our first case actually come about 2 weeks after our drill. So this is a real case that we practiced report on these patients. This is a resuscitation room. Now, our initial experience was not that grateful and not that great because the first 4 cases all die. But why? Because they are already in a very poor shape. Because before we can do a report, the patient already have a cardiac arrest, although resuscitated with return of spontaneous circulations. But it certified that they are already in a very poor shapes. So we cannot save any one of them, although some of them are very young, they're 28, 38. This is the oldest among those. So we look, and starting from our 5th case, we start to have some changes, and we can shorten our time. Activation time is shorter, and the balloon inflation time is shorter. We just take about 10 minutes from the time we puncture the skin to the time where we can inflate the balloon. And so after a few cases, we learned that we have to activate the people early, although we will insert the report when the systolic blood pressure is less than 70. But once the patient have the blood pressure less than 90, we will activate the team, make it ready. Once the target blood pressure reaches 70, then we proceed. If the patient can be maintained or even improved, then we can withhold the report. So after that, we have done 4 more cases, and then 3 survive and 1 death. And the activation time, procedure time shortened. This is the only mortality case. Is an 80-odd years old lady, because it is because the anesthetist just refused to admit the patient in the operation theater for resuscitation and breathing control. So, and also this patient suffered from cardiac arrest. So we have no choice but do the report in the emergency room, so that the evidence is willing to admit the patient in the operation theater. But of course, firstly, the patient is very ill, very old, and the activation time is so long, the patient eventually died. So let's come to the second last, or the last of the part of the presentation is whether you will put on a report or not in the emergency room. Where should you send the patient to? Now, luckily, we have this hybrid OR with an NGO's facility or capability, but not all hospitals can have these luxuries. So you still have to decide whether you should send the patient to which area. The only area that you shouldn't send the patient is to the CT suite. Now, this is a very controversial topic. Whether you embolize, that means you stop the arterial bleeding first, or you pack the pelvis, that means stop the venous bleeding. Because according to the literature, 85% this kind of patient might have a pelvic venous bleeding. So it's obvious that we should stop the bleeding from higher trans. But the problem is that this is a low pressure system. Probably we can control with pelvic binding and also fluid resuscitations or blood transfusions. But this is a high pressure system in the arterial side. So should we just embolize the patient first? Very controversial. There's no RCT, as far as I know, because the number of patients is so small in each center, and there's so many heterogeneity of patients, because patients may suffer from multiple injury, not just a single pelvic injury. And most of those recommendations or algorithm are level 4 evidence. So where should we go about? Now, I've do some research, and actually, there is a different group of people who have tried different pathway. So in the late 90s, 80s, people try to send patients to embolization. 90% of patients die, probably because the patient is very ill, or they are not targeting on the right target for stopping bleeding. Even with in some good studies, even with successful control of the bleeding, their mortality is still very high. Anatomical studies, some analysts find that even in patients with exsanguinating fracture pelvis, some of patients even don't have major arterial injuries. So embolization will be a wrong step or wrong priority. For how about the venous bleeding? Postmortem, in these very early studies that again, they show that the very small percentage of them have venous bleeding, arterial bleeding. Most of them suffer from blood loss from venous side. And it was demonstrating in an artificial model that with an intact retroperitoneal space, it can hold up to 5 liters of fluid and create a pressure of 30 millimeter of mercury, which is high enough to stop bleeding from this low pressure system. But the caveat is that the retroperitoneum must be intact. But this is not the case in many patients with fractured pelvis. The retroperitoneum line actually is already breached because of the fractures. So this is explored and properly give low use to our real-time patient management. And many times, even in very severe patients, the whole pelvic floor was disrupted. So this is the blood and the fluid you infuse will lose fluid, and it's kind of another way of seeing it is kind of open fracture pelvis. So so where should we go then? Now, pelvic packing has been using for stopping venous bleeding in US in the 60s, but resulting in low improvement in mortality. But it was challenged that because it was performed too late, when the patient is pre-moribund or even like our first few cases of reborn, the patient is already suffering from cardiac arrest. So at that time, even you do it, probably it's not your use. European used it in the 90s, but now they changed a little bit because the American used a transabdominal approach, which already will disturb the retroperitoneal space, because you have to, if you go through the transabdominal approach into the peritoneal cavity, you have to go to the retroperitoneal cavity by splitting or by incising the retroperitoneal line, which already stop one a very important temporal effect. So the European make more clever. So in the late 90s, they do the retroperitoneal or called the pre-peritoneal approach, and which seems more, and they also do it earlier, not until the patient was very sick. So there seemed to be some success. So that follow that patients start to adopt that venous bleeding stoppage by retroperitoneal packing is kind of a standard of care nowadays, and it was included as kind of a damage control surgery. So the disadvantage, of course, there's two different way. Packing, of course, can stop the venous bleeding, but it's invasive. And angio is an endovascular technique. It's just less invasive. So there's a pros and cons of the two. So how about a combination of that? So this is what we are doing now in our center. Although not all the hospitals in Hong Kong will practice the same. Because pelvic packing will be our first line, because our surgeons are always 24-hour in-house. So they are the one who is most accessible. Then while we are doing the packing, we already summoned the interventional radiologist to come back. And then by the time the surgeon finished the packing, or finish the external visitor, the radiologist will be there waiting for them to embolize the artery. So this is our pathway. Basically, if the patient have a positive fast, we will open up the abdomen, stop the bleeding like a ruptured spleen or liver, and then if still unstable hemodynamically, we will do the angiograph and angiography and try to stop the bleeding, and at the same time also pack the pelvis when the surgeon is opening up the abdomen. They will do it retroperitoneally. Apart from stopping the bleeding from the through the laparoscopy, they will also do a retroperitoneal approach to pack gauze over there. All right. So if the patient is fast negative, we'll transfuse patients, still unstable. We'll go to the operation room. The office surgeon will fix the pelvis with those fixators, and the surgeon will pack the pelvis. It's still unstable. We will already, the intervention radiologist will be there already. They will embolize as much as they can. And then afterward, of course, we will send the patient to the intensive care unit. So if you have only one chance, what will you do? So our choice is easy, is to send the patient to the endovascular or operation theater to do that 3-in-1. So this is a typical case. It happened early in the morning, luckily, about 9:20. So patient arrived in the VOR, and then the anesthetist is doing whatever they can to try to hemodynamically control the patients. And you can see the orthopedic surgeon already strapped and waiting there for the external visitor. So it takes a bit long, about 20 minutes for the anesthetist to stabilize the patients, put in all the lines, and the orthopedist will stand by there, and then after and putting all the close monitor, you can see orthopedic surgeon now is putting on this external visitor. It takes them about maybe 20 minutes to complete the procedure, while the general surgeon was standing behind. And once they've completed, the general surgeon will step in and then try to do this retroperitoneal packing. They stand another 20 to 30 minutes to stop the venous bleeding, and then the radiologist will be again waiting. And because this particular case have also ruptured bladder, so the urologist are also there to put in a suprapubic catheter together with the general surgeon. So that's really the reason why you take 30 minutes for the packing. Usually they take 15 to 20 minutes only, but there's another 10 minutes for the suprapubic catheter. And now the interventionist radiologists will come in to embolize the artery, and they take a little bit more longer time for this particular difficult case, because they try to do a selective or highly selective embolization to the internal iliac artery. But most of the time now, we'll just do the embolization to the whole internal iliac artery. So they completed the procedures, stopped the bone, venous, and arterial bleeding all in the same facility. And of course, at the same time, the anesthetist is trying to replace the patient with a massive transfusion protocol. So after that, after the patient being stabilized, and you can take care of the other injury, like the extremity injury, or send the patient to the CT scan, like the imaging, the thorax and the brain. In synthetic case, we also need the cardiothoracic surgeons care for the other multi-organ injury. So in our EVOR, we can also do a very quick CT of the brain, so we don't need to move the patient to the CT suite. So the neurosurgeon will have an idea whether the patients have any significant intracranial injury, rather than send the patient to the CT suite and then coming back for another procedures. After that, we'll send the patient to the intensive care. So this is our regular rhythm. I don't want to disturb you or bother you again. So this is what we call the 3-in-1 procedures being practiced, stopping the bone, venous, and artery. And our result. Now, when I moved to the emergency department, we start this in the initial stage. Our surgeon will go in all the time to open up the abdomen. You can see those blue bar is the mortality. So there's very high mortality at those days. So after that, we try to do embolization. That means we try to do minimal invasive procedures. It seems that we have some more survival, but the mortality is still very high. Then we start to practice this 3-in-1 with external visitor, retroperitoneal packing, embolization. We start to see more and more yellow color, the numbers, which is survival. So this is pretty old data, 2010, and I can show you some little updates. So what we call this is the phase 1, phase 2, and phase 3. So in the phase 1, mortality is very high, 73%. Phase 2 is 40%. In the phase 3, we'll come down to about 20% of mortality. Many patients not dying from hemorrhage nowadays, but dying from other organ injury, like the severe brain injury. Now, in the old days, before 2008, when we start this, and geography and embolization and pelvic king, the survival is just about 30%. Now we can increase it up to 2/3. So we published this in the Journal of Trauma and share our experience of this 3-in-1 about 10 12 years ago. Now, this is the more recent data have I shown previously. Now our mortality is stable about around 20%, except this particular year. So it seems quite promising, but we're still not satisfied. And so that's the reason why we try to introduce a report. Hopefully we can further drop this mortality to a lower level. But as I said, many of the patients not dying from hemorrhage nowadays is dying from other organ injury, especially the brain injury. So compared with this angio group and packing group, it's just a small number. You can see this 20 odd cases. We take a few years to maybe 2 or 3 years to accumulate, and you can see that the angio and the packing group, the number is small, but you can see the packing group seems to a combination of treatment can have a more significant injury result in terms of mortality. And so the mortality is still very high if you just do an angio, but whether we do a packing at those days, it seems much more useful. So we give up angio alone. So we'll do packing, but subsequently we do 3-in-1 with all those procedures done at the same time. But even with do a packing, we have already significant improvement in terms of decreasing the mortality by replacing packing with angio. So there's a number of figures and parameter, like in the survival group, the blood pressure is usually higher, 110 versus 55. Those blood pressure usually is high in the survival group. That means the survival group is basically less severe injury patient. So it's not like comparison. So we have GCS, a less severe injury in the survival group. The ISS is less severe, only 29, but versus the survival group is 49 or 50. And so the physiological state is better in the survival group. So that overall, all in all, that means that the survivors are usually the one who is less sick. So that is one of the reasons why they have a better rate of better survival. So I would like to conclude that for patients with exsanguinating pelvic fracture, for the kind of patient that we saw, they are usually limited injury to the lower part of the body. So when they arrive, they are still awake, they are yelling in pain, and they are dying in front of you. So it's not difficult to recognize this group of patients because of they have a major mechanism. They have a very unstable hemodynamical status. You can use a very simple maneuver to exclude non-hemorrhagic source of shock or the other abdominal bleeding or thoracic injury. So rather you exclude those, the only possible sort of major bleeding is from the retroperitoneal space, and majority of time is from the pelvis, which you can use not too difficult to see on just a plain pelvic X-ray. Your resuscitation measures should be very aggressive. Recently repetitive report too. And you need to an agreed protocol within your trauma team members, including the surgeons, orthopedic surgeons, anesthetists, and radiologists, because it is a waste of time if you're trying to argue who should do what first in the emergency room when the patient is dying. Because remember, we only have one chance. If you do it right, you can save the patient. Otherwise, you're spending your time taking maybe an hour or two in the emergency room while seeing the patient exsanguinating. So in our limited experience, if you cannot do 3-in-1, I would suggest that you may persuade your surgeon to do the packing rather than persuading your interventional radiologist to do the embolizations. Firstly, because surgeons are usually 24/7 available, while the interventional radiologist may not. And from a result, although the patients in the survival group have a better hemodynamic status, but the patient with packing seems to have a higher survival than those patients with just embolizations. So this is a very limited experience, which is I don't think we can collect a big samples for a meaningful scientific comparison, but this is a very limited experience. So what we do now is we try to do is a teamwork with a very clear protocol for our staff, and hopefully we try to improve the survival. So by that, I would like to end my presentation, and I welcome any questions from any one of you.
Thank you so much for sharing your 3 or 4 decades of knowledge in just 1 hour, doctor. It just proves that when a surgeon becomes an emergency physician, how much of a difference it can make in the patient outcomes.
Yeah.
So thank you for that. And you said immediately after fast positive, you will shift them to OR, not to the CT scans, right?
We never send patient unstable hemodynamic patient to the CT scan. But if the patients have a fast positive, it depends on how positive it is. If this is a very small rim of fluid or blood in the right Morrison pouch, for example, we may make a different decision, because if the breathing we believe is mainly from the pelvis, we will still do the 3-in-1 without opening up the abdomen. Because you open the abdomen, you will lose the intra-abdominal pressure, which can help to contain the breathing. So unless it's a very positive fast scan with a very significant intra-abdominal breathing, our surgeon will open up and try to stop whatever breathing, like most likely is a ruptured spleen or a ruptured liver. But it's just a very small breathing. We will still control the breathing from the pelvis first.
Okay, and the radiologist is able to help from the home itself, or do they have to be at the OR?
Which one? You mean the radiologist?
Interventional radiology.
Oh, now of course, if the patient arrive during office hour, of course they are in the hospitals. But many of the time, our patients come in the long office hour in the middle of the night. Our interventional radiologists usually they have to come back from the home. They promise that in 1 hour they will make everything ready, so that they will arrive at the hospital maybe within 45 minutes and do all the preparations. But during that time, we can take the patient to the OR, fix the bone by the orthopedic surgeons, and pack the pelvis retroperitoneal space by the general surgeon. It's just about time. When they arrive, they can scrub up and then do the embolization. So this is our reason. So because I think this is a practical way, and from our early experience, embolization don't have a very good survival benefit over just venous breathing, venous breathing packing. So we choose the packing first before embolization for both practical reason and from our limited experience.
Okay, for the fluid, do you directly go with the blood, or do you try with any saline or crystalloids?
No, we try to give blood drip. So after we set the IV, of course, we use the maybe the plasma-like or the normal saline to flush it until we get the blood ready. We will give blood transfusion continuously. So without trying to less the crystalloid and try to give a packed cell and continuously. We have 6 units of matched blood in our ED. We can ask for more if needed, but usually we don't need to use more than 6 because the patient by then will be on the way to the operation theater.
Okay, some of the residents are commenting like it's a wonderful presentation, sir, for giving us an insight journey about the pelvic fractures.
Yeah.
And
yeah, you are
I
most
agree
welcome.
Yeah, I agree with them. It looks like no more questions from the audience. So thank you so much for joining us for today.
Thank you.
We'll be
Thank you.
concluding the session.
Yeah, thank you spending time. Thank you. Bye-bye.
Bye.